Hello and welcome everyone to another virtual program put on by the Macular Degeneration Association. My name is Dustin. I am the Communications Director for the Macular Degeneration Association, and we are happy to welcome you to this program. We also would like to thank our sponsors, Keenly being Tarsus, for sponsoring this program. We appreciate their support and they help us to bring these programs to you. We also want to thank everyone that was on today and remind them that we are a 501c3 nonprofit. We work to bring information to people who need education about their disease or about their relative's disease so that we can provide you with as much information as possible to help you in your day-to-day lives. We are now going to be turning our attention to a subject of, is it dry eye or Demodex Blepharitis? This talk is being brought to us by Dr. Brujic. He is a 2002 graduate of the New England College of Optometry. He is a partner of Premier Vision Group, a successful 4-location optometric practice in Northwest Ohio. He practices full scope optometry with an emphasis on ocular disease management of the anterior segment and specialty contact lenses. He is active at all levels of organized optometry, and he is on the editorial board for a number of optometric publications. He has published over 400 articles and has given over 1,800 lectures, both nationally and internationally, on contemporary topics in eye care. We'd now like to introduce you to Dr. Brujic, and you have the floor, sir.
Good afternoon, everybody, or good late morning, depending on where you are in the country here viewing this. As Dustin said, I'm Dr. Mila Brujic, and the intent, the purpose for today's discussion is to really unravel what I refer to as this labyrinth of dry eye disease or blepharitis, specifically Demodex blepharitis, because these terms sometimes get used interchangeably, sometimes not. And what I want to make sure that everybody is fully aware of after you leave this discussion today is just having a clearer understanding of what dry eye is, what causes dry eye, and what some of the treatment options are. I also want you to understand too what blepharitis is, how it's similar symptom-wise, yet definitively different from what dry eye disease is, and what some of those treatment options are as well too. And I would encourage every single person on the call today, if you have any questions about anything we're talking about throughout the discussion, make sure you answer those questions in the Q&A box, which you should see either at the top or the bottom of your screen. And make sure that you're asking those as we're going through the information, because if you're thinking it, most of the other people are probably thinking it as well too. So to really kind of start this discussion off, I always think it's important to understand, first and foremost, normal anatomy, because we have to understand normalcy before we can understand what happens in the situation where you don't have normalcy. And what you're actually looking at here is a cross section through the eye and the eyelids. And to give you perspective, if you look at the video of me, imagine that you cut me in half. And that's actually what you're looking at. You're looking at the eyelashes right here. You're looking at the eyelid right here. And then you're looking at the eyeball behind the eyelids and everything that you see with the eyeball. Now, what we're going to be focusing on today is the tear film, which is what you see expanded here on the right-hand side. And the tear film is that small, thin little layer of tears that lines the surface of the eye. Now, there are 3 distinct layers to this tear film. And again, we can't see it because it's so small, but it's the lipid layer, or what I'll commonly refer to as we discuss it today, the oily layer. But lipid and oily layer really kind of mean the same thing. There's the aqueous layer of the tear film, or the watery layer, which actually composes most of the thickness of the tear film. And then there's the mucin layer. And the mucin layer is really what allows the tear film to actually physically stick onto the surface of the eye, which you can see right here. The corneal epithelium is actually the very front of the cornea where the tear film physically sits. Now, I want to make sure we're crystal clear on this next topic, because this can actually get a little bit confusing. But there's two types of tears that our body produces. The first type of tears is this nice, highly organized structure that I'm sharing with you right here, where you can see that oily layer on the far right, or the outside of the tear film, the watery layer and the mucin layer. And then there's a second type of tear that our eye produces. And that second type of tear is produced in response to emotions. So if you see a sad movie and you cry for emotional reasons, or if somebody upsets you and you're crying for emotional reasons, that will be that second type of tear that's released. That is a very, very different tear, in particular because of the volume of fluid that's actually released on the surface of the eye. That's actually released from a small little lacrimal gland that's located almost right above and underneath the orbital bone that you can actually touch and feel when you press along that right under your eyebrow. So again, that second type of tear really isn't what we're talking about today. It's that first type of tear that we're talking about that always sits on the surface of the eye at a very, very thin layer. And in a normal situation, it literally, when you blink, you don't feel your eyes. And the reason why you don't feel your eyes is because of this thin little layer of tears that's physically present on the surface of the eyes. Now, this next video was actually produced by Alcon several years ago, but it describes the dynamic nature of the tear film better than anything I've ever seen. So what you're actually getting a real glimpse of is the tear film at a level that you'll never see it. This is that oily layer that sits on the surface of the eyes, the one that I was just talking about in that last diagram. And this oily layer actually acts as an anti-evaporative layer. It physically holds all of the tears on the surface of the eye. This second layer right here is the aqueous or watery layer. Remember, this layer is the layer that actually provides most of the nourishment to the ocular surface. And you can see all these small things floating in the fluid. All of these are proteins and enzymes and things that keep us safe and protected against microorganisms that want to invade us. And the third thing we see here is this, what we refer to as this mucin layer that interacts with the surface of the eye. Look at the surface of the eye. It has these small little microvilli that actually interact with the tear film. And these are important to understand because, again, this is what gives the ability for those small, tiny little cells on the surface of the eye to really embrace that tear film and keep it tugged onto the surface of the eye. And any one of these three layers that don't work, what starts to happen is you'll actually form dry spots, which you'll see as these dark areas in the tear film forming right here and right here and right here and right here. We're going to talk about these in just a second. But what happens is your tear film actually starts to form these dry spots. And these dry spots, as represented here in this cartoon depiction, actually shows you what happens to the surface of the eye. The cornea doesn't like to be exposed to the air. And when it gets dry enough, it will in fact get exposed to the air enough so that you'll actually have a drying response and your eye will almost feel like it's on a desert. And when that happens, you can actually start hurting the eye. And we can actually see this when we look at your eyes with our diagnostic equipment. So what you're actually looking at here is the way we view the ocular surface. Now, here's the cool part about a lot of this discussion here today, folks. If you've never seen what an eye doctor actually looks through to physically see your eyes, you're actually going to see that today in a lot of the videos that I show with you. It's going to be like, it's going to be like I'm actually physically looking at the eyes through my slit lamp because we have video recorders on our slit lamps, and you're going to be seeing those videos. So you're going to be seeing how I see things through my slit lamp throughout this discussion. So the first thing that I want to show you is one of the ways that we view the tear film. Now, there's a specific dye called fluorescein, and for some of you, you may have actually had this placed on your eye before. So on the left-hand side, you can actually see what the fluorescein, we call it a fluorescein strip. But again, there's this small little orange end right here, and then there's this other portion of the strip that you actually hold on to, and you apply it to the inner part of the lower eyelid, as you can see here on the right-hand side. But what you do is you put a little drop of either saline or water on the end of this strip. And then what you do is you touch it to the inside surface of the eyelid. And when that happens, when you touch it to the inside surface of the eyelid, the patient's eye almost turns a little bit either yellowish or orangish from that dye. And then what we can do is when we look through the instrument that I just showed you, this instrument, which we refer to as a slit lamp, which actually you can see one physically right behind me, right here, we have a slit lamp. But when you look through that slit lamp, you'll actually see what the eye physically looks like. Now, we have to look at the eye with special filters. So some of you may have had an eye exam where you get a light that's shone at your eyes and it's a blue light. And that's what this is really representing here. And the reason why we put blue light on your eyes after we look or after we put the fluorescein on your eyes is because it helps highlight the tear film. And what you're going to see here next is what that looks like. So again, now you're in the moment here over the next 30 minutes, you're going to be getting the same view that we see as eye doctors when we view a patient's eye. So this is what we're looking at first. Now I want to describe what you're seeing here, and you can actually see the patient's eye blinking. Again, this is a very, very high magnification. So you may not be used to looking at a patient's eye at this level of magnification, but you can see the eye physically blinking. And what that fluorescein dye actually does is it diffuses into the thin layer of the tear film. And when it diffuses into the thin layer of the tear film, what it actually does is we can actually see what that tear film looks like in real time when we look at it with a blue light. What we expect is we don't expect any of these tiny little dark spots to actually start forming. And you can see them on both of these tear films. You can see after the person blinks, it's a nice smooth green hue. And then you start to see all these little dark spots formulate. All of those dark spots are areas where the fluorescein is actually drying out. And that represents to us where the tear film is actually starting to dry out. Why do I share all of this with you? This is the first indication that somebody may have dry eye or that their eye isn't producing a sustainable amount of tears to support the surface of the eye. Why this is important to understand is that we oftentimes think about somebody with dry eyes as having eyes that are uncomfortable. And although that's true, and people will say, my eyes feel dry or irritated, the second most common complaint that a dry eye patient has is, I don't see quite as well either. And the reason why is we need a nice smooth tear film over the surface of the eye. I don't expect to see a dry spot in the tear film for about 10 seconds or longer after a patient blinks. And in this individual, you can see that the dry spots are forming very, very quickly after they blink. So now they don't have a smooth tear film. They have a lumpy tear film because there's dry spots in it. And when somebody has a lumpy tear film because of dry spots in it and light hits it, it diffracts. And when it diffracts, the way that the patient will perceive their vision is, my vision seems fuzzy. And what sometimes patients will complain about is, I have to rub my eyes or I have to close my eyes or just relax before my vision gets clear again. And what they oftentimes don't even know that they're doing is they're trying to forcefully sweep a fresh set of tears over the surface of their eyes so they can have nice, consistent vision again. That's one of the challenges with dry eye. One of the other challenges with dry eye is what you're looking at here. And you can see this person first and foremost, you can see where the tear film is breaking up quick, but you can also see these tiny little green dots on the cornea. These tiny green dots are not supposed to be there. We actually have a name for them, clinically referred to it as corneal staining. And some of you, if you've been to the optometrist or the eye doctor, you may have heard of this term corneal staining. What that really is irritation on the surface of the eye, usually from some type of dryness. And that's what's happening here. So all these little dots where it looks like I took a green little marker and put all these dots on, that shows me that this cornea has been dry for a long time, and we need to rehabilitate that surface of that cornea so they're not showing those dry regions or dry areas. There are other signs of dry eye that we can see on the surface of the eye. One of them is there's a different type of stain that we can put on the eye called lissamine green. Lissamine green is very similar to fluorescein. It's just another dye that we can use, but you don't have to look at it with blue light like I talked about earlier. We just look at it with a regular white light. And you can see when somebody has this irritation that even on the white part of the eye or their conjunctiva, you can actually see this irritation that's present here as well too. So there's another piece to this whole story that we need to be very, very cognizant of, and that is how the tears are being produced. There's one thing that everybody on the call here today needs to be very, very aware of, and that's something called the meibomian glands. The meibomian glands are critically important because they produce that oily layer on the surface of the tears. So remember we talked about the three different layers of the tear film, and just to review, it's the oily layer, that's the outer layer. The middle layer is the aqueous or the watery layer, and the inner layer is the mucin layer. The meibomian glands produce the outer oily layer, and the meibomian glands are actually within the eyelids. And you can actually see this cartoon depiction here of the meibomian glands. This is them right here. You have about 30 to 40 of them on the top lid, or you have about 20 to 30 of them on your lower lid. Normally, you can't see them because they're hidden. They're within the skin of the eyelid tissue. And this is, again, the meibomian gland right here. Now, why do I point this out? Well, you can see where they end. They actually have small little holes right here, right behind the eyelashes on the upper and the lower eyelid. And every single time we blink and our eyelids touch, a small amount of oil is squeezed out of these glands and it produces that oily layer on the surface of the eye. So what we've learned about in substantial amounts over the last 15 years is how meibomian glands actually affect the health of the eyes. And what you're looking at here is me assessing what the quality of the oils being produced from the glands are. So you can see this patient's eyelid right here, and you can see my thumb actually pressing up against the lid margin. And what you'll also see as well too is, again, me trying to press oils out of the oil glands, but I can't get any oils out of those oil glands. So this is somebody who has meibomian gland dysfunction. Some of you may have heard that term before. All that means is the meibomian glands are dysfunctioning and they're not producing oils the way that they're supposed to. We actually have tools. This is one of the tools right here. It's called the meibomian gland evaluator. And what this does is it gives us the ability with this small little end to produce just a little bit of consistent force on the surface of the outer eyelid. And in doing so, we can actually determine whether or not, with just a little bit of pressure, we can actually produce any oils out of the meibomian glands. And this tells us whether or not the meibomian glands are working the way they're supposed to, or whether they're not working the way they're supposed to. This is an example of another patient who has meibomian gland dysfunction. And you may be wondering, well, how do I know this patient has meibomian gland dysfunction? Well, first and foremost, let's take a look at what we're looking at here. I'm looking at the patient's upper lid and I'm turning that upper lid up just a little bit. And you can see the eyelid margin here. Now, what I'm going to do here in this next one is I'm going to actually show you just the picture of the eyelid margin. So again, you can see the gland, or you can see the lashes right here. You can see the eyelid margin right here. But you can see this large globule right here. This is actually oil that's capped on that meibomian gland orifice. So remember that little hole that I told you about that produces oil? This is a cap that's actually formed from the meibomian glands that are producing thicker than normal oils. And because of that, that thicker than normal oil is physically capped on that lid margin. This is another sign that we have meibomian gland dysfunction. And again, this is important for us clinically to identify so that we know how to best treat patients who have dry eye, and if they have a dry eye because they're not producing enough of the aqueous layer or because they're not producing enough of the oily layer. If they have meibomian glands that aren't working the way that they're supposed to, it's probably a situation where they're not producing enough oils. This is what the meibomian glands actually look like. So what you have here is a patient who's looking up. You can see my thumb here pulling down on their lower eyelid. And on the inside surface of that lower eyelid, you can actually see where the meibomian glands are. You can see these small little yellow nubs right here. But you can also see where the meibomian glands are missing. We actually expect the meibomian glands to traverse along the whole length of the eyelid. And you can see in this situation, it doesn't really traverse the whole length. It's only at the very, very margins here. This is a person who has glands that are shortening, and these are individuals that are important to identify. We can actually, in our offices, we can utilize specialized technologies where we can actually see how long or how short those meibomian glands are. It's called infrared imaging. And you can see on the very far left, and I'm going to start at this top left picture here. This is actually called the Heiko-Polt meibomian gland scoring scale. And it's because it was created by Dr. Heiko-Polt out in Germany. And what you can see here are these white strands right here in the eyelids. And these white strands right here represent the meibomian glands in a healthy individual. And then when you look over here, this is just the cartoon depiction of what we would expect to see here. But you can see in this individual, they have a lot of meibomian glands. When you go down here to this area right here that I'm circling, the second one from the bottom on the left-hand side, you can actually see there's still white glands that are present here, but there's some areas where you don't see any glands right here. And you can see that the glands are much more shortened here. That's what we call meibomian gland dropout. That's what we're trying to avoid in people because it will eventually cause dry eye symptoms. This is an example of an individual that I took infrared imaging on in my office. And you can see how this patient, for the most part, has these really, really long, healthy glands, which is what we like to see in patients' eyes. So when we think about dry eye, and again, I would encourage those of you that have questions, make sure you're putting them in that question answer box, because when I'm done with the discussion today, we'll go over everything that we talked about or went over. So when we're thinking about how do we treat dry eye disease, because we talked about some of the reasons that we would have that, and also some of the ways that we physically see that in the office. How do we treat dry eye disease? Well, there are several things that we utilize, and the first is something called artificial tears, what I like to refer to as supplemental tears. Those are things that you can typically find over the counter. They're usually best utilized when you get the recommendation for the exact type to use from your eye doctor, because they'll know what over-the-counter drop is best for your type of dry eye. But you literally use it just to supplement the tear film. What I refer to artificial tears as is that it's kind of like a Tylenol in the dry eye world. It doesn't necessarily make your eye produce more tears better, but what it does is it makes you feel better. And that's what Tylenol does. Tylenol makes you physically feel better, and artificial tears will do the same. And it's good to supplement the surface of the eye if need be. The second thing that we have are medications to treat dry eye disease. And there are several medications. Some of you may be familiar with some of them. There's a category called anti-inflammatory medications. And those anti-inflammatory medications are things like topical corticosteroids or steroids. That reduces inflammation very, very fast. But steroids can't be used for a long period of time because they can cause intraocular pressure to be elevated, and they can also cause cataracts or premature cataracts to form. So we have other agents that we can use for longer periods of time. Some of you may have heard of Restasis or cyclosporin 0.05%. Some of you may have heard of a medication called Cequa. Some of you may have heard of a medication called Xiidra, and some of you may have heard of a medication called Vevi. All of these medications are approved to use in attempts to reduce inflammation that we see on the eyes. Inflammation is very, very different than infection. And I want to make sure that you're crystal clear on both of these. Inflammation is something that occurs when a tissue gets warm, heated, and oftentimes there's sensitivity in the tissue. For example, I did a lot of push-ups yesterday, so my right elbow feels inflamed. It's sore. I don't have an infection. Nothing's invading my elbow, but I just have warmth, heat, and some level of sensitivity there because I have physical inflammation that's present in the elbow. if I have a cut on my hand and a bacteria gets in there, I'll have inflammation as well too, but I'll also have an infection. So again, infection is very different than inflammation. And when you think about inflammation, inflammation is something that we see or we tend to see with dry eye. So we have a lot of these medications that we can actually utilize for them. There's another medication that helps us produce more tears. That's a nasal spray called Tyrvaya. The nasal spray is utilized once in the morning and once in the evening on the inside of the outer nostril wall on each eye. Excuse me. And it helps your eyes produce more tears. Some of you may be wondering, well, how does a nasal spray help me produce more tears? The mechanism of action is beautiful here. So we all have a nerve that innervates our whole face, including the inside of our nasal cavity and the outside of our nose. I know that I'm touching myself because I can feel it because of this trigeminal nerve. The trigeminal nerve is also what creates sensitivity on the surface of the eye. And it also is involved in something called the lacrimal functional unit. So it helps the eye produce more tears. We found that when we can stimulate it on the inside of the nasal cavity, we can actually help the eye produce more tears over time. There's also another new medication called Mibo. Mibo is actually a molecule that was engineered and designed to look exactly like that oily layer on the surface of the eye. So what it's approved for is a 4 times day dosing schedule. You put it on the eyes, and what it does is it latches on to the oily layer of the tear film, so that top layer, and it prevents the underlying tears from evaporating. So it essentially holds the tears on the surface of the eye for longer periods of time. And then there's also several procedures that can be utilized to help patients with dry eye. And I want to go over some of those just so you have more familiarity. So if you hear about any of these, you know what's happening or what's going on. And the first is something called LipiFlow. So what's LipiFlow? Well, in order to understand what LipiFlow does, you have to understand why somebody has meibomian gland dysfunction. So remember that video that I showed you where I was trying to press oils out of the meibomian glands in the lid? And I want to see something that looks like olive oil, something very, very thin and oily. And as I was pressing, I couldn't see anything coming out of those glands. The reason why I can't see anything coming out of those glands is because the meibum, which are the oils that are normally produced, are actually a solid lipid or oil instead of a fluid oil. An analogy that I can give you, and the best one that I've kind of come up with, is think about butter. Butter is actually just simply an oil or a fat in a solid state. Now, what happens to butter when we put it in a frying pan? When we put butter in a hot frying pan, it melts and it turns into an oil. And that's what's happening in the eyelids. Something's occurred so that those oils that are being produced look thicker. They look more like butter than they do olive oil. So what do we do with those patients? Well, one of the things that we can do is we can just have them apply warmth to the outer surface of the eyelids. And we have specific masks that we can actually prescribe or you can get from your eye doctor, where you actually put it in a microwave for usually 20 to 25 seconds and rest it on your eyes for 10 minutes. And for some people, that's enough to start melting those oils. For some people, it's not enough. So when we need to take the next step in how we melt those oils, there's 3 procedures that we can do. And the first is called LipiFlow. Now, LipiFlow, what this does is it actually puts a little cup on the surface of the eye. So on the outer eye, it's literally inflating this small, tiny little air bladder and putting pressure on the eye, then releasing, pressure on the eye, then releasing, pressure on the eye, then releasing. And simultaneously, or at the exact same time on the back surface of the eyelid, it's actually producing warmth. So you're warming the eyelid from the back, and from the front, you're actually putting a pressure on the eyelid. And in doing so, you're warming the oils in the meibomian glands, and you're also putting pressure on them. And what you then do is you melt and evacuate those glands so that the meibomian glands themselves can start producing healthy oils again. And that's how LipiFlow works. There's another device that was more recently approved called the iLux device. And what this does, as you can see, is it provides a little holder for the lower eyelid. And then on the front of the eyelid, you actually, it's almost like a little gun. You put pressure on the front of the eyelid, but you also put warmth on the front of the eyelid. So you're simultaneously putting warmth and pressure on the front eyelid. And the clinician or the person that's doing the procedure can actually see the oils that are coming out of those glands through a small, tiny little viewing window right here. There's a third procedure called the tear care procedure. So what's the tear care procedure? Well, the tear care procedure actually are small little kind of electrodes that you place on the lower and the upper eyelid on both the right and the left eye. It warms the eyelids for 15 minutes. And then what happens is we have a special, excuse me, we have a special set of forceps that physically we can press the oils out of the lid margins. Now, what you're looking at here is an eyelid right here, and you're looking at this special set of forceps that I'm using on a patient. And it looks a little bit shaky because whenever there's movement at this level of magnification, you can see it. But take a look at the oils that are starting to come out of this patient's meibomian glands. This was something that we could never express anything. And until we warmed them and we put a little bit of pressure on them and attempted to express them, we could never get any oils out of these glands. And you can still even see how thick they are even after we put heat on the glands. Take a look at all of this that's coming out of those glands now. Again, we're attempting to empty those glands out so that we can get those oils that are congested out of those gland margins in attempts to get the eye to produce healthier oils again for that patient's tear film. Again, that's everything that we're trying to do here. Take a look at all of this congestion that's now coming out. Again, now we have the ability for those meibomian glands to start producing healthier oils again. Now, some of you may have heard a term called ocular rosacea. Ocular rosacea is a term that we use to describe patients who have meibomian gland dysfunction, but also have facial rosacea. Well, what's facial rosacea? Let's talk about this a little bit because this is important. This is where you have visible redness on the cheeks, and you can see it here. You can see these blood vessels that are encroaching closer to the surface. And this redness right here that you're seeing right here and right here is because small, tiny little blood vessels are actually encroaching closer to the surface of the face. And this is caused because of inflammation around the glands that are located in the actual skin. The glands that are located in the skin actually come embryologically from a place very similar to the meibomian glands that we just spent so much time talking about in the eyes. So when something affects the glands on the skin, it will likely also affect the meibomian glands, which is part of the reason why we in eye care are now starting to look at much more sophisticated ways to treat the eyes in a more global way. Because we know that if we can make the facial rosacea better, we can actually make the ocular rosacea better. And we have a few ways to do this. The first way that we can do this is by having somebody take oral doxycycline. Oral doxycycline is a medication that's readily available, and you utilize it, and what it does is it reduces inflammation in the skin. Now, the challenge with oral doxycycline is for a small percentage of patients, it actually can cause stomach upset. Some individuals are allergic to doxycycline, and you also have to be a little bit cautious when you're out in the sun because it does make you a little bit more sensitive to UV. So you have to make sure and certain that you're utilizing UV protection when you're outside. But what we're now starting to embrace as well too is what we refer to as light therapy. Well, what's light therapy? Well, there's two ways that we can introduce specific wavelengths of light to the surface of the face and the eyes. The first way is something called low light level therapy, where you actually have 5 panels that are about 6 inches from your face, and you close your eyes, and we expose you to certain levels of red light, which actually target these blood vessels. So they get into the actual dermal layer of the skin, and they kill off these blood vessels that are encroaching to the surface, and that actually reduces inflammation. And then also infrared light that actually helps with inflammation. So you have these two wavelengths of light that actually work synergistically to help these individuals. In addition to that, there's actually something called intense pulse light therapy, or what's commonly referred to as IPL, where there's a light source that's directly pressed up against the skin, and there's pulses of light that are sent to the surface of the skin at a higher intensity in attempts to actually get rid of these blood vessels that are congested at the level of the skin. And what this actually does is reduces inflammation in the face and around the eyelids for these patients. There are other treatment options that I think are important to understand, and these are newer treatment options. This is actually something referred to as Rinsada. This has only been available for less than a year. But for those patients with really severe dry eye or really severe allergic conjunctivitis, this is actually a special tool that's placed on the end of a syringe, and we can actually do a thorough wash of the surface of the eye with saline. And you can see with this small, tiny little hook, there's saline that comes out here on the back end of the hook and right out of the end of the hook. So why do I share all of this and what this actually looks like? Well, I want to show you what this looks like from a patient's perspective. This is actually how the procedure is performed. So you clasp the upper eyelid and you pull that upper eyelid up and you pour the rinse in that space between the upper eyelid and the globe or the eyeball itself. And you do the same thing as the patient's then looking up on the lower eyelid. And we inject about 5 milliliters of saline. And what we find is that we can rid the ocular surface of a lot of the inflammatory markers that start to build up there for those patients with severe dry eye disease. And again, there was actually a study comparing just a standard saline rinse versus the Rinsada rinse. And hands down, without a doubt, the patients who went through the Rinsada rinse did remarkably better than those patients who just did a standard saline rinse. Now, there's one other procedure that I wanted to touch on and go over here as we were talking about dry eye that's important to understand. But before I talk about the procedure, it's important to understand how normal tears flow on the surface of the eye. So what you can see here is the lacrimal gland that I was talking about. Under normal circumstances, it produces just a little bit of fluid that's constantly on the surface of the eye, along with oils from the meibomian glands that are in the eyelids. And both of those combine to produce the tear film. And then what happens is the tears actually evaporate off the surface of the eye just from the air, which is part of the reason that if you have dry eye, you know that in some environments, your eyes bother you a lot more than in other environments. But the tears actually go onto the eye, and then they drain through small little puncta in the corners of the eye. Every single person has a puncta on the inner part of their lower and their upper eyelid. And these puncta actually drain into the nasal cavity and drain out here into the larger nasal cavity. And it's part of the reason why if you're ever crying for emotional reasons and there's a lot of tears that you're producing, you'll oftentimes want to blow your nose. And the reason is because the system's getting overwhelmed and it's producing such a high level of tears that you now have a lot of fluid that's physically being produced in that nasal cavity. So what are some of the solutions for these patients? Well, if somebody's not producing enough tears, we can actually put small little plugs in these puncta. And this is just a schematic representation of what this looks like here. So again, in this little hole, we can put plugs here. Well, how do we actually do that? Well, here's where I'm going to show you what it looks like from my perspective at the slit lamp. And you can actually see two different size plugs actually being placed in the patient's eye on the left-hand side and a different patient on the right-hand side. But again, you can see what happens with these plugs. We put them in the lower puncta, we push them down, and then when they're appropriately placed, you don't physically see them anymore. Again, they disappear because they sit in the tract between where the eye is and where the nasal cavity is. So again, if you're looking at the video on the right-hand side, this is what we call the intercanthus. This is the puncta right here, that small little hole. And the plug that we're placing goes right into that canalicular tract. So again, it's just a way to help retain tears on the surface of the eye for longer periods of time. This is how we actually prep that hole. So what I'll usually do is I'll open up the hole with jeweler's forceps on the left-hand side, and then we put the plug in place and we push it down with a set of jeweler's forceps. So I'm seeing a few questions come in. Again, we're going to get to all the questions. Trust me, I will not be done with you until every single question you ask is answered. So the question then becomes, what are the ramifications of putting plugs in the appropriate dry eye candidates? Well, let me show you what those ramifications are and how positive they can be. This is a patient who comes in and presents to me initially, and see all of these large little dots on the cornea? We don't expect to see any of those dots on patients. This is because the surface is dry, and this is how we clinically see that the surface is dry. We place plugs in this patient's eyes and take a look at the cornea 2 weeks later. No, it's not perfect, but there is definitive, we've moved this patient in the right direction. So again, for the appropriate candidate, punctal plugs work great. So we spent a lot of time talking about dry eye. So now let's talk a little bit about blepharitis. By definition, anything in healthcare that we have with the term itis on it, so itis, just describes a situation where there's inflammation to that tissue. So for example, conjunctivitis. Conjunctivitis means there's inflammation to the conjunctiva. Blepharitis, all that describes is there's inflammation to the eyelid. Blepha describes the eyelid. So what does blepharitis actually look like? Well, you're seeing it here at a high level. Now, let me show you and let me kind of decode to you what you're looking at here. You're looking at a patient's eyelid, and you're seeing the eyelashes right here, large eyelashes, again, just because they're magnified. But you can also see the blood vessels that are present right here in the eyelid as well, too. We don't usually expect to see blood vessels that are that prominent. Now, what I'm going to show you in this next slide is I'm going to show you this same patient, but I'm just going to show you pictures of this patient as opposed to an actual video. The video is how we see things clinically. Now, what I've done is I've just said, all right, let's just look at the picture and let's kind of define what we're seeing here. The reason why this patient has blepharitis, I know, is for two reasons. And what you're looking at is this individual on the left-hand side, same patient on the left and the right side of the screen. The only difference is on the right-hand side, I'm actually looking at this patient at a high magnification, or a high, like just magnifying view. So on the left-hand side, you can actually see that there's subtle little things at the base of the lashes, these waxy deposits. We call them collarettes. On the right-hand side, you can actually see those collarettes much more evident. See all this waxy deposit that's present right here? We don't expect to see any of this on a patient's lid margins, and when we see it, it's abnormal. The reason why these patients have these little waxy deposits at the base of the eyelashes is because something's growing in the hair follicle that's producing them. I want to show you this other patient, and you're going to see 4 views of this same patient again. Imagine you're sitting at my slip. You're seeing the view from the eye care provider or your eye doctor. So when we look at that eyelid margin, we can see the lashes right here that are very, very evident. And you see small, tiny little waxy buildup at the base of the lashes. I'm going to show you this same patient at a little bit of a magnified view. And when you look at this patient with the magnified view, you can actually see the waxy buildup right here, right here, right here, right here. All of this is waxy buildup. We call that collarettes at the base of the lashes. I'm going to show you the same patient at a higher magnified view, just so you can get a better appreciation of what the eyelashes are not supposed to look like. So see this right here, this waxy buildup around this eyelash? That's not supposed to be present there. And you can even see it at a greater magnification here, this waxy buildup, all this stuff right here, this waxy buildup right here, and this right here. None of that's supposed to be present on the eyelashes. And the reason why that's present is because there is something called an ectoparasite. We oftentimes refer to it as a mite. It's called a Demodex mite. And Demodex mites actually grow in the hair follicle. The hair follicle is nothing more where that hair actually grows out of the skin. So at the base of that hair follicle, there's physically a root. And within the root, these small little mites actually grow. Now, here's where I don't want you to be concerned. Demodex sounds, when we talk about mites, we always get so concerned. But these mites are found in large amounts in our population. Almost everybody has some type of Demodex that can be found in some hair follicles. The only caveat here is that in most normal individuals, they're in such low concentrations that they never produce these waxy buildup or deposits at the base of the lashes. If they're allowed to replicate and really culminate into large populations in the lash follicle, what then starts to occur is you can get this waxy buildup at the base of the lashes. And when you get this waxy buildup at the base of the lashes, it's because there's an overpopulation. We know that it's pathognomonic. At this point, there was a large study that looked at these people who had these waxy deposits. They pulled those eyelashes and they found in every single one of these individuals that there was more Demodex than they would expect to find in these individuals. So that makes it easier for us clinically because now we know what that means when we see these waxy deposits. So there's a whole bunch of ways we can treat this. The way that we used to treat this is with lid hygiene. We oftentimes call lid hygiene things like lid scrubs, where you take and you can buy these over the counter and you just scrub your eyelids clean. There's a way that we can perform this in the office called a microblepharoexfoliation procedure, or what's commonly referred to as a BlephX. And what this is it's a tool where this end with a a surgical grade micro sponge located on the end of it right here. We literally just press this button and this bit spins very quickly. And when it spins very quickly, we can actually clean the eyelid margin with it. We can also clean the eyelid margin with something called hypochlorous spray. This is available in a number of different things, but we know that hypochlorous acid, even though it says acid, it's actually very comfortable. Like even if you spray it on the eyes, it doesn't sting or anything like that, but it kills bacteria and microorganisms. It neutralizes inflammatory toxins. It helps suppress the body's natural immune system so we see less inflammation, and it prevents biofilms from performing or from accumulating on the surface of the eyelid. And it's present in a number of different formulations. These are just some of the bottles or some of the brands of hypochlorous spray that are currently present. Some of them you can find over the counter, some of them are prescription, some of them you can find at your eye doctor's offices as well, too. Relatively recently, there was a brand new drop that was FDA approved back in August of 2023. September of 2023, we got first access to this technology. And what it is a drop. And the active ingredient in it is up here on the left-hand side. It's called lotilaner. And lotilaner is actually toxic to Demodex. So what you do is you place a drop on each eye twice a day for 6 weeks, and it actually kills the Demodex mites that are located inside the hair follicles. You use it just like a regular drop, and the drop's actually been studied and it was engineered to actually make it so that the active ingredient finds the hair follicle and gets into the hair follicle and gets to the Demodex mites that are overpopulated there and virtually kills them and gets rid of all the collarettes. The reason why this is important to understand is people with Demodex blepharitis sometimes present very similarly symptom-wise to people with dry eye disease. And what we've actually found is that some of these patients, when we treat their Demodex blepharitis, their dry eye symptoms actually disappear. I'll give you a perfect example of that patient. This was a patient that I saw who has Demodex blepharitis. And again, you can see the waxy buildup that's present here at the base of the lashes and the eyelid margin. I'm going to show you this exact same patient 6 weeks later. And take a look at how different this eyelash margin looks like. Again, I want to show you this again, just so you know the true power of appropriate treatments for people. So again, this is the initial presentation. So this is how the patient came in to me, and they had heavy symptoms. And this is how the patient was 6 weeks later by simply using that eye drop. So we're fortunate in eye care that we now diagnostically, like when we're looking at you, we have different ways to determine what's causing the problems and the issues on a patient's eyes. And because of that, we can now, with a more targeted approach than we ever have before, we can hopefully get people more comfortable over time. All right. With that said, I've left a lot of time here for questions, which I want to do. And I just see a bunch of questions coming through. I'm going to answer every single one of these one at a time. I'm not going to say even the person's name, whoever asked the question, I'm not going to say their name. I'm just going to read the question and then I'll answer those questions. So the first question is, Cystane eye drops are OTC, which I use twice daily for dry eyes. Is that good to use? So I'm going to answer this question very generically. Yes, it is good to use, and the Cystane eye drops are a nice drop to use. Saying that, I would make sure that you consult with your eye doctor to make sure that you're using the best eye drop for your eyes. There's subtle differences in these formulations that make certain eye drops better or more appropriate for certain people with certain types of symptoms. So just make sure you're consulting with them to make sure that they're okay with it. The other thing as well, too, that's really interesting with over-the-counter eye drops is every single company's looking at the influence of preservatives in the eye drops that we use. And they're saying, how can we make these drops better? And usually the answer to that is they're packaging them as preservative-free drops. So now Cystane has several drops that are preservative-free as well, too. So just consider that when you're thinking about the eye drops that you're utilizing. All right. I notice that at times my eyes are very dry and irritated. At other times, my eyes run water constantly. This is one of the most common complaints that we have. So the individual that asked this question, you're not alone. Let me first and foremost explain why this is happening, because this is important to understand. Remember at the beginning of the lecture, I told you that there are two types of tears that your eyes produce. The first type of tears is that thin layer of tears that your eye produces that's always there. So right now, my eyes are producing tears. I don't even know it because the layer is so thin that when I blink, my eyes are comfortable. I don't physically feel my eyes, and I'm seeing things consistently. So my vision's never going in and out. There's a second type of tears that your eyes can produce. Let's say for something, for example, the other doctor came in here, just punched me in the arm. Well, I'd probably start crying because it would hurt. And I first and foremost, I'd cry because I'd say, Dr. Jacoby, why are you punching me? The second thing is just because of the pain, I would start crying. That's a second type of tear that's being produced, and that's more watery in nature. Now, here's where it's really important to understand this. If your eye is deficient in the first type of tear that I talked about, the tear that's always on your eye at a thin layer, and it's not producing that in sufficient quantities, what will happen is your eye will respond by producing that second type of tear. And that second type of tear is that more watery type of tear that will run off your face and that you'll have to wipe off. That's the most common reason why sometimes an individual will feel like sometimes my eyes are dry and it's like they're not producing anything. And then other times my eyes are constantly watering. That's why that's happening. And what's usually the answer to stop that second type of watering is to help your eyes produce that first type of tear better. I notice that I am unable to cry. Why is this? There are several reasons for that. There are certain individuals that are born without a lacrimal gland. That's a very, very uncommon thing, but it can happen. There are also individuals who have severe autoimmune conditions. Those severe autoimmune conditions, specifically Sjogren's, but other immune conditions can cause this as well too, because autoimmunity isn't specific. For those of you that have autoimmunity, or for those of you that know people who have autoimmune diseases, you know that even if you have rheumatoid arthritis, that's not usually the only thing that's bothering you. Sometimes you feel like, man, my vision is cloudy. Sometimes you, or my mind is cloudy. Sometimes you feel like my stomach isn't right. There are other things that it cross reacts with. And the lacrimal gland is one of those things that it can cross react with. So if you have an immune response against the lacrimal gland, it can actually cause it to be so destructed that it won't produce aqueous tears anymore. Are all the artificial tears the same? How do you know which ones to use? So to answer your question, no, all artificial tears aren't the same. As a general recommendation, do not use anything that is a store brand product, meaning don't use anything that's not name brand. And even if you're using something that's name brand, you need to be cautious of this. You need to get direct recommendations from your eye doctor. There were approximately 40 over-the-counter artificial tears that were recently recalled because things were growing in them, because they were unsafe, because they were causing eye infections. So just make sure you're communicating with your eye doctor on that. But the simple answer is no, all artificial tears are not the same. They all have different moisturizers, all have different wetting agents in them. At one time, I was told to use baby shampoo to clean my eyelids. Is that still correct? Yeah, so that's actually a recommendation that we've gotten away from. And what we've actually found is, although the baby shampoo can get the scurf and the stuff off of your eyelids, it's tough on the eyes itself. So what the recommendation for that now is one, just lid scrubs that are in individual packages, or two, hypochlorous spray. If those don't fix the issue or alleviate the symptoms, you may actually be better suited for something like, remember the procedure I showed you called Blefx, where you can clean the eyelid margins? That works great. Or you can also as well to maybe a candidate for Xdemvy, that new medication I was talking to you about. Can Demodex mites get into the inside of your body? Fortunately, a good question. Fortunately, they cannot. They can only live on the surface and they only live in hair follicles. What is interesting though is that, and just to be clear, it's not anything that anyone specifically is doing. Sometimes when I say this, people think that they have Demodex blepharitis because of hygiene issues. That is not the case at all. It's usually an imbalance of the oils that actually keep these microorganisms in check, and they just allow them to overgrow. And what we also find is that people who have rosacea, they have a higher propensity towards having a Demodex overpopulation along the eyelash margin. And when we look very closely at the hairs, even on the skin or on the cheeks, we can actually see small, tiny little collarettes, or these collarettes on the facial hair as well, too. Why do I have much red soreness in the inner corner of my left eye? I have blepharitis and dry eye. Well, it's probably because of those two things that you have it. And those two things just physically need to be treated. And the good news is there's fortunately a lot of good treatment options for both of those. Just make sure you're having that direct communication with your eye doctor on that. If you have Demodex mites and use eye makeup, your makeup is now contaminated. How often should makeup be changed, specifically mascara? This is a great question. So once you go through so if possible, and sometimes you make the decision not to do this, but if possible, what you want to do is, while you're treating the Demodex blepharitis, you stop using makeup for the 6 weeks of the treatment. If you're like, I can't really do that, you can sparsely utilize the makeup that you have now, just while you're being treated. Then at the end of the treatment, pitch it, get rid of all the makeup, and start brand new from scratch so that you're not recontaminating your eye. Can diabetes cause dry eye? Diabetes isn't necessarily a cause of dry eye, but diabetes increases the risk of developing dry eye. We think part of the reason for this is diabetes affects the vascular supply. And because everything is controlled by blood vessels, we think this compromise actually makes it so that the tear film is not being produced as adequately anymore. Is there a specialist that I should see for this, or can any eye doctor take care of this? That is such a good question. So every eye care provider specializes in different things. Here's what I would recommend. If you have an established relationship with an eye care provider, start there. That's the first place you start, because they will then tell you, oh, yep, this is what you have to do to make this better. Or they'll tell you, this really isn't my area of specialty, but fortunately, we have this practitioner who's also an eye doctor who really spends more time on this. During my presentation, I was just looking at my cell phone, and I actually had a few fellow colleagues who were texting me saying that they had just referred me patients to look at for specific dry eye cases. So again, the first place to start at is your eye care provider. Make sure you have that conversation with them, and then they'll refer you to that next level if it's required. I had lupus and ended up having to have chemo for cancer. Cancer lupus was put in remission. Now I can no longer cry. Does this still mean I have an autoimmune problem? Not necessarily, but it does mean that you may have challenges moving forward with dry eye disease. We work a lot with people who have had combination issues, autoimmunity by itself, cancer treatment by itself, or a combination of those two. But what these treatments can sometimes do is permanently damage some of the organs that actually produce the tears on your eyes. So just make sure that you're communicating that with your eye care providers. So because there are treatments that we know function better when we see that. So again, just make sure you're communicating that. Is Dove unscented soap a good cleaner for my eyes? I have blepharitis and dry eye. I clean my eyes with soap mostly twice daily. Do I need prescription for the spray? So Dove is gentle and the unscented is gentle. The challenge is, and the caveat is if you get it in your eyes, it's not gentle. So when oftentimes this stuff is described, it's described as gentle on the skin, not necessarily on the ocular tissues, which is why you need to be hyper cognizant of this. My recommendation is make sure you're communicating this with your eye doctor, because again, if it is caused by Demodex blepharitis in particular, we never had the ability to get rid of these mites, and it would just keep coming back and coming back and coming back. There's a way that now you can potentially, if it is Demodex blepharitis, you can actually get rid of those mites that are the underlying cause. And actually, the company that actually produced the drop, a year later, after a single treatment, 80% of those patients were still clear of Demodex blepharitis. So again, for 80% of people after a year, they have a cure rate. Again, not a temporary, a cure rate. So it is important for you to communicate with your eye doctor on this, because the space of blepharitis treatment, again, even if it's been as early as 6 months ago that you've seen your eye care provider, it's just evolved and changed so much with the information that we have access to and availability to. So make sure that you're communicating your specific case. I notice that when I lift my lid and look down, there are red streaks on the white of my eye. Is this caused by dry eye? Good question. It could be, but there's something else that can cause that as well too, called superior limbic keratoconjunctivitis. So again, what's most important to do is make sure you're asking an eye care provider on that differential and saying, hey, what is this? Is this normal, or is this something that I need to be concerned about? Because it can be caused by dry eye, can be caused by superior limbic keratoconjunctivitis. It can also be just a benign issue. People just sometimes have peculiar like little spots or nevi or even blood vessel or vascular supply on different parts of the conjunctiva or the white part of their eye. And that may be all that it is. What vitamin should I use to help my dry eye? Oh, now this is an interesting question. So normally what we've always prescribed is omega-3s derived from fish oils. Omega-3s derived from fish oils, if you take it in a capsule, the best way to determine whether you're taking a good quality fish oil is when you look at the bottle, you'll see two numbers. You'll see the total milligrams of the fish oil, and then you'll see the amount of omega-3s that are in it. The omega-3 should be 70% or more of the total fish oils in that capsule. If that's the case, you're utilizing a good omega-3, and that should help your dry eye. Relatively recently, there was a new nutraceutical that was actually approved called NutriTears. And this is in the dry eye section. So it's not in just the general nutrition section. It's in the dry eye section right beside the Blink eye drops. The formulation is called NutriTears, and it has high concentrations of lutein, which we've always known are good for the inside of the eye. But there's just a recent study that showed that it's good for the front of the eye as well, too, in dry eye. So those are two nutrients that you can take. All right. Those questions were absolutely phenomenal. Donna, I think we've gone through most of the questions here. I think we've gone through all of them.
Yep, I believe we have as well.
Excellent.
Dr. Brujic, we want to thank you so much for the wonderful information and for answering all the questions that these wonderful people had for you.
Of course, Dustin, thank you for having me too. This was a great group, and those questions were absolutely fantastic.
Well, on behalf of the Macular Degeneration Association, we would like to thank everyone for coming today. We would like to remind you that we do have more virtual programs coming up throughout the year, so please check our website, macularhope.org. We also have several live programs around the country. So if you would like to come to one of those and you're in one of the cities that we're visiting this year, please also check our website and you will see the dates and times for those. Otherwise, we want to again thank Tarsus for sponsoring this program, and we'd also like to thank all of you for coming, and especially thank you, Dr. Brujic, for giving this wonderful lecture. And otherwise, we'll say thank you and have a great day.